Hi, my name is Beth DeYoung. I'm an assistant professor of pharmacy practice at Concordia. I also work at the Milwaukee VA where I run a metabolic syndrome monitoring clinic for patients taking second generation antipsychotics. Most of my training has been in mental health, and today I will be talking to you about the medications that we use to treat depression.
In terms of learning objectives, you should be able to recall the mechanisms of action of the antidepressants listed to aid in the selection of the most appropriate patient-specific medication, should identify first-line antidepressants most likely to be involved in drug-drug interactions. You will not be required to know specific interactions for the purpose of the exam, but you should recognize which antidepressants are more likely to inhibit CYP enzymes and are therefore more likely to be involved in drug-drug interactions. You should also be able to compare and contrast the significant adverse effects associated with our first-line antidepressants, and finally, design a pharmacologic treatment plan for a patient with depression using patient-specific characteristics.
We have several pharmacologic treatment options available to us, and I have them broken down into first and second line treatment options. Our first line treatment options are going to be our selective serotonin reuptake inhibitors, our serotonin, norepinephrine, and reuptake inhibitors, and then mirtazapine and bupropion. Things that are used second or even further down the line are monoamine oxidase inhibitors, tricyclic antidepressants, things like trazodone and nifazodone, vilazodone, and vortioxetine. Vilazodone and vortioxetine are new to the market, so it's just that we don't really know their role in therapy yet, and that's probably why they're used second line. They're also very expensive at this time. There are also several other treatments that we won't have time to talk about today. I won't get to talk about any of these treatments, but we have several complementary and alternative treatments that are available over the counter, things like St. John's wort, SAMe, omega-3 fatty acids or fish oil, vitamin D, and L-methylfolate. There's also prescription augmentation strategies that you may see psychiatrists use, things like second-generation antipsychotics, lithium, thyroid replacement, and stimulants. All classes of antidepressants are equally efficacious. If you look at any given patient, certain patients may respond better to certain medications, but in the general patient population, there's nothing showing that one agent is more efficacious than another. So the choice of agent is really going to depend on multiple factors such as side effects, comorbid conditions, patient preference, or if they have a family or their own history of response to a medication. The cost of the drug is usually very important to patients, as well as drug-drug interactions. Listed here are the selective serotonin reuptake inhibitors that we have available on the market. I have them listed in both generic and brand name. Pharmacists tend to speak in generic, and many of the psychiatrists or patients tend to speak in brand name. So throughout the presentation, I'll be referring to these with their generic names, but here's the brand if you also would like to know those. Fluvoxamine is not actually used for depression anymore. We'll still use it for anxiety, but it's not really used for depression for reasons we'll talk about later. So then listed here are serotonin and norepinephrine reuptake inhibitors. Desvenlafaxine and levomilnacipran are still brand name. Levomilnacipran is actually one of the newest antidepressants on the market, and it's actually an isomer of milnacipran, which was approved for treatment of fibromyalgia and has been on the market for a while. So levomilnacipran appears to just be a stronger inhibitor of norepinephrine reuptake than venlafaxine or duloxetine, but there's no proof at this time that it's any more effective than the other agents. Desvenlafaxine is actually the active metabolite of venlafaxine, and there's also no evidence that it's any more effective than venlafaxine. Duloxetine is used also to treat fibromyalgia and diabetic peripheral neuropathy. So sometimes this is a great option for patients that have neuropathic pain and depression. And our miscellaneous first-line agents are bupropion and mirtazapine. Bupropion can also be used for smoking cessation, in which case then it is marketed under the brand name Zyban. In terms of mechanism of action, the selective serotonin reuptake inhibitors do exactly what their name implies. They inhibit the reuptake of serotonin from the synapse. It's pretty nice because they don't have a lot of effect on muscarinic, histaminergic, or alpha-adrenergic receptors, which can cause a lot of side effects that we'll see with agents that we'll talk about a little bit later. From a mechanistic perspective, just recall that with muscarinic receptors, you can end up with anticholinergic side effects, histamine receptors, sedation and weight gain, and with alpha-adrenergic receptors, you can end up with orthostatic hypotension. You'll also notice that I have something listed here with the desensitization and downregulation of presynaptic serotonin 1A autoreceptors. So the 1A autoreceptor is really responsible for letting the neuron know that there's already serotonin in the synapse. So when serotonin is released in the synapse, it'll feed back on that 1A autoreceptor, which is actually in the image on the slide, it's shown as a 1B autoreceptor, which is fine, don't worry about that. But it feeds back on this 1A autoreceptor and says, hey, there's enough serotonin in the synapse, don't release any more. Well, it takes a while for that to desensitize and downregulate, and part of this then may be responsible for the delay in onset of SSRIs.
The SNRIs also do what their name implies, so they inhibit the reuptake of serotonin and norepinephrine. Venlafaxine is an SNRI, but it's unique in that it preferentially inhibits serotonin reuptake at doses less than 150 milligrams per day and norepinephrine at higher doses. Bupropion inhibits the reuptake of norepinephrine and dopamine. So of the medications we've discussed so far, it is the only one that does not act on serotonin and has more of this action on dopamine. So it's a little bit unique in its mechanism, and for that reason it's a really good add-on medication if you're wanting to add something to an SSRI or an SNRI, because you're not duplicating the same mechanism. Mirtazapine is a central alpha-2 receptor antagonist, which causes serotonin and norepinephrine to be released into the synapse. So to some degree, they're similar to the SNRIs in that you'll end up with more serotonin and norepinephrine in the synapse, but with the SNRIs, they're inhibiting reuptake, and mirtazapine is actually causing these neurotransmitters to be released into the synapse. It is an antagonist at serotonin 2 and 3 receptors, and we'll talk about the implications of that in just a moment. And then it is an antagonist at histamine 1 receptors. So again, going back to the pharmacology, we're more likely going to see things like drowsiness and weight gain with mirtazapine. The purpose of this slide is to just help review the normal physiology with our serotonin receptors. So normally if you stimulate the serotonin 2 receptor, you'll get things like sexual dysfunction, insomnia, and decreased appetite. Whereas you stimulate the serotonin 3 receptor, you'll get gastrointestinal adverse effects. So if you recall, mirtazapine is an antagonist at serotonin 2 and 3 receptors, and that's why we have less sexual dysfunction and less GI adverse effects. But then we can get sedation and increased appetite with that medication as well.
In terms of the pharmacokinetics, I don't expect you to have these numbers memorized for things like half-life. The numbers are different than what you may see in your text, and that's okay, again, because I'm not expecting you to have these memorized. I just want you to have a general idea. And one of the biggest things to take away from this is that fluoxetine has a very long half-life. It will stay in the body for a long period of time. If you look, all the other agents are listed in terms of hours, whereas fluoxetine has a half-life of 4 to 6 days. And its active metabolite, norfluoxetine, actually has a half-life of 4 to 16 days. So very long time that it stays in the body. Some of the other agents like venlafaxine, desvenlafaxine, duloxetine, they all have fairly short half-lives, and that'll be kind of implicated a little bit later in some withdrawal symptoms that we'll talk about. All of these agents, you have to pay a little bit of attention to renal and hepatic adjustment. However, I will say that it's generally safe to use these agents in patients with renal and hepatic impairment. The dose adjustment recommendations are usually fairly vague, and where they'll maybe recommend dose adjustments but not be too specific in how to go about that. So sometimes it just says may require a lower dose. With the SNRIs, venlafaxine, desvenlafaxine, duloxetine, levomilnacipran, those are cleared renally. So if you have a patient with renal impairment, it is important to make sure that you're adjusting the doses appropriately. There's a lot going on this slide, and these medications are pretty highly implicated in drug-drug interactions. It's important to recognize that pretty much all of these medications are metabolized by CYP450 enzymes, but they also inhibit the CYP450 enzymes. And so this is what this table is showing you. It's showing you the CYP enzyme inhibitory potential of each medication. And rather than memorizing which enzyme is inhibited by every single drug, what I want you to notice is that fluoxetine and fluvoxamine are most involved with this CYP inhibition. And this is one of the reasons we don't really use fluvoxamine for depression. We have a lot of other agents that are effective, and there's just no need to deal with all those drug-drug interactions. So of the agents we use, fluoxetine is the one that's most implicated in drug-drug interactions. Paroxetine and sertraline kind of fall in the middle. And then citalopram, escitalopram, and the SNRIs are all pretty good. If you had to pick one for a patient that was on multiple medications, any of those agents would be reasonable, as well as bupropion and mirtazapine.
I mentioned when I talked about the mechanism that there is a delayed onset with these medications. Typically, you will notice some improvement within 1 to 2 weeks of starting them, but it can take 4 to 6 weeks and maybe even up to 8 weeks to notice the full therapeutic effects of these medications. Again, this is thought to be due to the time it takes to desensitize and downregulate that serotonin 1A receptor. While that receptor is working, their serotonin feeds back on it and tells the nerve terminal not to release more serotonin into the synapse. It takes a while for that receptor to burn out, so you can get more release of serotonin into the synapse. One thing that is difficult for patients is that the onset of side effects is immediate, so it can be very difficult for them to take and tolerate the medication. They may be tempted to stop or discontinue the medication before they get a chance to fully notice any benefit. Escitalopram is the S-enantiomer of citalopram and is more potent. The R-enantiomer that is included in citalopram does not contribute to the efficacy, but may contribute to side effects. However, both agents are equally efficacious. And then I previously mentioned that desvenlafaxine is the active metabolite of venlafaxine, and levomilnacipran is the L-enantiomer of milnacipran, which is approved for fibromyalgia.
In terms of symptom remission, you should notice some benefit in those first couple of weeks. Usually the first thing to improve is things like sleep and appetite. Within 1 to 3 weeks, you'll notice increases in activity, improvements in memory. Patients may say that their eating patterns and sleeping patterns are pretty normal by now. And then within 2 to 8 weeks, that's where you start to see the relief of depressed mood, patients being less hopeless and helpless, and thoughts of suicide. So if you're not noticing benefits within those first few weeks, may mean that you need to increase the dose or potentially even consider switching agents. However, it's important to recognize that it can take up to 8 weeks for full effect, so you don't want to give up on the antidepressant too early. Great. I just want to highlight some of those drug-drug interactions and use some patient cases to show you some potential issues you could run into. So with the first case, we have a patient that has been taking metoprolol tartrate for the past year for hypertension. He has started on paroxetine to treat depression. Paroxetine inhibits CYP2D6, which actually metabolizes metoprolol. So if CYP2D6 is inhibited, metoprolol cannot be metabolized as quickly, and this increases the risk for bradycardia and hypotension. So you could potentially just pick a different antidepressant. However, almost all of them have some CYP2D6 inhibition. Or if necessary, you could switch to a different antihypertensive. Otherwise, clinically speaking, what you should just do is have the patient monitor their heart rate and blood pressure. If their heart rate already isn't too low, like less than 50, this really shouldn't be too much of an issue for patients, but you do want to counsel them on that they could feel dizzy or lightheaded and that it's important to monitor their blood pressure and pulse. With the second case, we have a patient who is prescribed clopidogrel after suffering a myocardial infarction with stent placement. He started on fluoxetine for depression. Fluoxetine is a CYP2C19 inhibitor, which can reduce clopidogrel efficacy. CYP2C19 is responsible for converting clopidogrel's prodrug to the active metabolite. So basically, fluoxetine inhibits the enzyme which makes clopidogrel more active, and therefore clopidogrel may not work as well for this patient. Once again, you could just pick a different antidepressant that doesn't have this CYP2C19 inhibition. And then for the third case, we have a patient that has been taking citalopram for depression for the past 5 years. He is currently hospitalized with pneumonia and will be treated with linezolid. So linezolid is actually an inhibitor of monoamine oxidase, and we'll talk about this a little bit more later when we talk about the monoamine oxidase inhibitors. But with that, due to that inhibition of monoamine oxidase, you can actually get buildup of the neurotransmitters, and this can place the patient at risk for something called serotonin syndrome, which we're going to talk about next. So what I want to highlight with these cases is that drug-drug interactions can be pretty problematic. It's not that I'm expecting you to memorize, again, which ones inhibit certain CYP enzymes, but I want you to realize which antidepressants tend to be more problematic, with the most problematic being fluvoxamine and fluoxetine. So if you get a patient case where a patient's on multiple medications, especially cardiovascular medications, you would not want to pick fluoxetine as your first-line agent.
We already discussed the potential for CYP-mediated drug-drug interactions, but we also have to be careful or watch for pharmacodynamic interactions. There are several other medications that can increase serotonin in the synapse, and sometimes if you get too many of these medications on board, you can put the patient at risk for something called serotonin syndrome. So listed here are some of the drugs that can also increase serotonin and are considered serotonergic drugs. However, this list is not all inclusive. Of the agents listed, monoamine oxidase inhibitors tend to be most problematic, and anytime I've actually seen serotonin syndrome, a monoamine oxidase inhibitor is typically involved. However, other medications that you may not traditionally think of, like linezolid, our synthetic opioids, and dextromethorphan, can also increase serotonin in the synapse. Triptans may not be as problematic as people once thought. It is thought that activation of the serotonin 2A receptor is typically required for serious serotonin syndrome, and triptans are actually agonists at serotonin 1B and 1D receptors. That being said, you'll still see this flagged as an interaction in practice, so I just wanted to discuss that a little bit. You'll recall from your cardio.
As mentioned, serotonin syndrome is caused by excessive central nervous system serotonergic activity, and it's usually associated with the use of multiple serotonergic agents. However, it can occur with one agent alone. And then I also said that the highest risk is with use of a monoamine oxidase inhibitor, although it could happen with anything like a SSRI or an SNRI. The symptoms can be fairly nonspecific in the beginning, things like abdominal pain, diarrhea, sweating. Sometimes patients will be shaky, but then they can develop more severe symptoms, including things like rhabdomyolysis, renal failure, cardiovascular shock, and death. So it is very important that patients are counseled on how to recognize these signs and symptoms, and that healthcare providers can also help recognize them and initiate prompt treatment if necessary. There is something we can do to help prevent serotonin syndrome, and that is that we should have a washout period when switching to or from a monoamine oxidase inhibitor. If a patient is on an MAOI and you switch them to a non-MAOI, you should have a 2-week washout period in which they do not receive the new antidepressant. Also, any medication without a long half-life, if they're on any other like paroxetine, venlafaxine, a tricyclic antidepressant, and you're going to switch to a monoamine oxidase inhibitor, you also use a 2-week washout period. And then the only one that's different is fluoxetine. And we mentioned already that this one has a very long half-life, so it stays in the body for a long time. So with this medication, you need a minimum washout period of typically about 6 weeks. So if you just remember the 6 weeks for fluoxetine, and with every other scenario, you need a 2-week washout period. In terms of dosing, you'll typically titrate the dose over the first few weeks as tolerated until you reach a therapeutic dose or the patient responds well to the dose that they're on. Again, you should see improvement in 1 to 2 weeks, but maximal response may not be reached for 4 to 6 weeks. Minimum effective doses have not been clearly established for many of the antidepressants, and the dose-response relationships tend to be unclear. So for this reason, you may see providers exceed the maximum recommended dose. Just use caution with doing so. Slower titration may be necessary for the elderly, patients with renal and hepatic impairment, those who have multiple comorbid conditions, patients who are taking medications that can involve drug-drug interactions that we talked about. Those are the types of patients where you may not be able to escalate the dose as rapidly. So you really need to weigh the benefits and risks of exceeding the maximum recommended doses. And as I've already said, this does happen in clinic, but you just have to recognize that sometimes you don't get more benefit. You just end up with more side effects. With citalopram, there's actually a recommendation to not exceed 40 milligrams due to the risk of QTc prolongation. They actually say not to exceed 20 milligrams daily if your age is greater than 60, in patients that have impaired CYP2C19 metabolism, or if they're on concomitant CYP2C19 inhibitors. Sometimes the problems that you run into with dosing can be that patients or providers will inappropriately increase the dose or do inappropriate dose reductions. You can see inadequate treatment durations in which they don't treat the patient long enough and give up on the medication too quickly, or where they'll just do a kind of a one-dose-fits-all strategy. I'll often see providers, just do small doses of antidepressants rather than getting to a good dose that really helps the patient. I don't expect you to have dosing memorized. This is something that can be looked up, and as mentioned, a lot of times providers will exceed the maximum recommended dose, so I don't need you to memorize those. I just want to point out a few things on here. Several of the medications can be dosed once daily. However, there are some that need to be dosed multiple times per day, which can affect adherence for patients. Duloxetine dose, typically with depression, we'll see people won't usually exceed around 90 milligrams. Those higher doses around 120 are usually used for neuropathic pain and peripheral neuropathy. And then paroxetine and mirtazapine are usually administered at bedtime to help with sedation. We'll talk about how those medications can make people feel sleepy, so it's helpful to have patients take those at bedtime. Another reason you'll often see doses divided twice daily is to help minimize side effects. Sometimes if a patient is not able to tolerate the full dose taken once daily, you can divide it twice daily to help with that. It's important when you're going to stop an antidepressant to not just abruptly discontinue it, and it's also important to inform patients that they shouldn't abruptly stop their antidepressant. And this is because patients can develop a discontinuation or withdrawal syndrome. This happens most commonly with agents that have shorter half-lives like paroxetine and venlafaxine, and it's least common with fluoxetine due to that long half-life. The symptoms generally resolve over 1 to 2 weeks, and they're not life-threatening, but they are uncomfortable. And so you can see many of the symptoms listed there are sort of like flu-like symptoms. Paresthesias are actually kind of like tingling, burning, pricking, or numbness of the skin. I've often had patients describe that they feel like they're being kind of shocked by electricity when they abruptly stop their antidepressant.
The antidepressants can be fairly difficult for some patients to tolerate, so education on these side effects is pretty important. As already mentioned, the antidepressants can initially cause or worsen anxiety and agitation before they help treat these symptoms. The GI side effects of nausea, vomiting, and diarrhea are fairly common, but patients will tend to develop tolerance to these side effects over time. They do tend to diminish after about the first week of treatment, and patients can take the medications with food or a snack to help minimize these side effects. Unfortunately, for some patients, they will have things like persistent nausea or diarrhea, and then we may need to switch the antidepressant. The sexual side effects can be very concerning to patients, and it may seem like it's embarrassing to counsel patients on this side effect or that they may feel uncomfortable, but because it is fairly common, it's important to have that discussion. And this can be things like decreased libido. For women, it can cause anorgasmia or increased ejaculation latency in men. So this is a problem for both men and women. Depending on the antidepressant, we can see either sedation or insomnia. And then we can see some weight changes, and patients are typically more concerned about medications that lead to weight gain. There are some side effects that are somewhat less common. We can see some type of movement disorders with these medications, and that is because serotonin can reduce dopamine levels, and dopamine plays a role in movement. You may see bruxism, which is grinding of the teeth, and then we briefly discussed the GI bleeding. And again, the mechanism responsible for this is that we have blockade of serotonin reuptake into platelets, and this leads to serotonin depletion in the platelets and diminished serotonin-mediated platelet aggregation. You can also see things like syndrome of inappropriate antidiuretic hormone. This tends to be more problematic in our elderly patient population or those who already have hyponatremia. Suicidal ideation is rare, but it's important to counsel all patients on this potential side effect. This is a pretty important slide because often we will choose agents for our patients based on the propensity to cause certain side effects. A lot of the side effects we just talked about are class effects, but some agents are more likely to cause certain side effects than others. Bupropion and fluoxetine are more activating. These are the agents that can cause more of that anxiety or agitation that I mentioned. They can also cause insomnia, so we will often dose them in the morning. Paroxetine is associated with anticholinergic side effects, which are drying side effects like dry mouth, difficulty urinating, and constipation. This medication can be particularly problematic in elderly patients, so I typically try to avoid paroxetine in that patient population. Sertraline tends to cause more diarrhea. Patients can adjust to this, but it can be problematic for some patients. The SNRIs as a class can cause elevations in blood pressure or hypertension, but this tends to be worse with venlafaxine. Citalopram and escitalopram can cause QT prolongation, and citalopram is more problematic than escitalopram. In general, these medications are not too problematic, but we need to be careful if we're going to combine them with other medications that are QT prolonging medications or patients who may already have a prolonged QT interval. I already mentioned mirtazapine and paroxetine can cause sedation, so we usually dose them at bedtime. Bupropion can lower the seizure threshold, so it's recommended not to give that medication to patients with a history of seizures. And then mirtazapine and paroxetine are most problematic in terms of weight gain. There are some pretty simple and straightforward things we can tell patients to help them manage the adverse effects associated with these medications. If patients are experiencing that anxiety or agitation, we can reduce the dose. We can also slowly titrate the dose to help prevent this side effect. Try not to increase the dose more than one dosage level every 1 to 2 weeks. We should tell patients to take these medications with food to help minimize the nausea, vomiting, and diarrhea. And if it's not a medication that causes insomnia, we can also have them take it before bed to try to help minimize that side effect. In terms of sexual side effects, sometimes adding a low dose of bupropion to an SSRI or an SNRI can help with the sexual side effects that patients experience. We can also add something like a Viagra to help with sexual dysfunction, but this isn't ideal because then that's another medication they have to take, which in itself has its own side effects. We could also consider reducing the dose, which doesn't always help, but it may help, or switching to antidepressants. Again, bupropion and mirtazapine are least associated with sexual dysfunction. The frequency of follow-up and monitoring in the clinical setting really varies, and appointment frequency can depend on the severity of the patient's illness, what type of social support they have, and the progression of their symptom change. Listed here is the ideal frequency of follow-up according to the guidelines, but I can say that in clinical practice this often does not happen just because of lack of provider availability. They recommend that in the acute phase of treatment, which is often the first 12 weeks of treatment, the patient should be seen 1 to 2 weeks after starting the antidepressant, then every 2 to 4 weeks. So the goal is really to see them at least 3 times within that first 12 weeks of treatment. Once the patient progresses into the continuation phase, which is often months 4 to 9 of treatment, the patient should be seen every 4 to 12 weeks. And then if they go into maintenance phase or more long-term treatment, you'll try to see the patient every 3 to 12 months if they're stable. Unlike a lot of our illnesses, we won't have drug levels or any type of blood monitoring or lab monitoring that we can do with these medications. So really with monitoring, we're just monitoring their response to treatment, if they're having any side effects, how they're doing with remembering to take the medication or their adherence, and if they're experiencing any suicidal ideation.
There are certain patient populations that we want to pay particular attention to, and one of them is the elderly. The elderly have a very high rate of suicide, and especially elderly men, because they have high access to guns and they're just usually don't have as much social support, so they're more likely to commit suicide. They often present with more physical complaints, so depression can actually be missed in these patients due to physical complaints of things like headache, insomnia, joint pain, dizziness, constipation. These are all actually things that can be signs of depression in an elderly patient. They also may be more sensitive to side effects. We talked about paroxetine maybe not being ideal in our elderly patients due to those anticholinergic side effects. The elderly are more at risk for SAADH as well as movement disorders with the antidepressants. You also want to consider renal and hepatic function in this patient population, as it's often decreased as we age. Elderly patients are usually on more medications, so we have to be cognizant of those drug-drug interactions. And then you may need to do a slower dose titration in this patient population to help prevent some of those side effects.
On the opposite end of the spectrum, we also have special considerations for our pediatric patients. Unfortunately, there is not a lot of great data in this area, especially in regard to medications, and a lot of what we do with children is extrapolated from data with adults. Pediatric patients may be more likely to present with irritable mood rather than the typical depressive symptoms, so make sure to watch for this, especially with teenagers. Fluoxetine and escitalopram are the only FDA-approved antidepressants for pediatric patients. However, all of the first-line antidepressants are commonly used, and so you'll see this often in clinic. All antidepressants have a black box warning for increased risk of suicidal thinking and behavior in children, adolescents, and young adults. What we've seen clinically is that this black box warning is not consistent with the most current research and clinical experience. After this warning came out, prescribers started prescribing less antidepressants to children, and the suicide attempt rates actually increased in this patient population. So you still want to make sure that you are providing treatment if a patient needs it, but it's very important to provide counseling to the patient and their parents so that they can help monitor for suicidal thinking and behavior.
And then in terms of pregnancy, SSRIs have the most published data on efficacy and safety. Paroxetine is the one that you have to take special note of. That one is pregnancy category D, and that's because in 2005 there was an FDA advisory indicating that paroxetine may increase risk for cardiac defects. Subsequent studies showed no increase in major birth defects with paroxetine, but it is still listed as pregnancy category D. Not sure that that's necessary, but if you have a lot of different options to choose for a patient, paroxetine may not be best anyways in a pregnant patient due to increasing risk for things like constipation. SSRI use during pregnancy may be associated with things like low birth weight, premature birth, and then withdrawal symptoms after the baby's born. And this can be a wide variety of things like irritability, jitteriness, difficulty feeding, and tremors. So a lot of pregnant women will worry about taking these medications while pregnant. However, it's important to counsel them that untreated depression is also associated with premature birth and low birth weight. So in all of these studies, both untreated and treated women basically had the same outcomes, or their babies basically had the same outcomes. So again, you really need to weigh the benefits and risks, and it's important to treat someone who has, moderate to severe depression. If a patient is feeling suicidal, obviously committing suicide would be a worse outcome than staying on an SSRI during pregnancy. Sometimes providers will continue the SSRI and then try to discontinue it in the third trimester, but again, this is very patient specific. You wouldn't want to stop an SSRI if a woman truly needs it. It would just be better to continue it throughout the pregnancy. These agents are excreted in the breast milk, some more than others. Sertraline is actually excreted least and fluoxetine the most. So if you have a mother that's breastfeeding, any of the agents should be fine, but if they want to be particularly careful, I would stay away from fluoxetine. Sometimes when this is excreted in breast milk, it can cause things like irritability, vomiting, and diarrhea. And kind of thinking about these agents and summarizing what we've learned, there's really a lot that goes into patient education when you're starting a patient on one of these medications. It's really important that you counsel them on that delayed onset, when they can expect to see side effects versus when to expect benefits, so that hopefully they can stick it out and get a good trial of the medication. What types of drug-drug interactions they need to be aware of, what signs and symptoms of serotonin syndrome look like. It's important they do not abruptly discontinue the medications so that they don't get those withdrawal effects. And then counseling on the common adverse effects that happen, things like nausea, vomiting, diarrhea, sexual dysfunction, changes in weight, potentially increasing anxiety in that first week. And then suicidal thinking is important to counsel for all patients. Patients should also avoid alcohol. As you know, alcohol is a depressant, so it kind of counteracts the antidepressant. And then counseling patients if they plan to become or are pregnant.
We spent quite a bit of time discussing our first-line treatment options, and I'm only going to briefly touch on the second or even third-line treatment options. And that's because oftentimes by the time patients get to these medications, they'll have been referred to a psychiatrist or someone who specializes in mental health. We no longer use the monoamine oxidase inhibitors first line due to their problematic drug-drug and drug-food interaction profiles. Tricyclic antidepressants can be very difficult for patients to tolerate because of their adverse effect profile. We tend to see them used more often for things like neuropathic pain or migraines, and not as much for depression. Trazodone would be an example of a serotonin antagonist reuptake inhibitor, and this medication is used more for insomnia. We no longer use it for depression first line because the doses required for depression are just way too sedating for patients. I am going to spend a little bit of time talking about vilazodone and vortioxetine just because these may one day be first line agents. Right now I have them listed as second line just because they're newer to the market and we haven't entirely determined their role. We typically don't use vilazodone first line just because it is newer and brand name only, and we don't have as much clinical experience with this medication. It has a unique mechanism in that it is a dual SSRI and a partial agonist at serotonin 1A receptors. So by stimulating that serotonin 1A receptor, it causes it to burn out faster, thus eliminating that negative feedback on serotonin release. However, it has not yet been shown to produce a more rapid onset. It is metabolized by CYP3A4 and 2C19, and to a small extent CYP2D6, so it is involved in CYP450 interactions. It has a very specific dose titration, and it is recommended to take it with food, and this helps improve bioavailability and also helps decrease nausea. The most common adverse effects associated with this medication are diarrhea, nausea, and vomiting, so that's why it helps to take it with food, and it can also cause insomnia. It is supposed to have fewer sexual side effects, but so far data indicates that it probably falls somewhere between placebo and SSRIs. Similarly to vilazodone, vortioxetine is brand name only and new to the market, so we just don't have as much experience with this medication. It does have multiple mechanistic properties, making it somewhat unique in that it is an SSRI. It's also an agonist at that serotonin 1A receptor, so again, in theory, this should decrease the time to onset, but this has not yet been proven. And then it's an antagonist at serotonin 3 receptors, so this should reduce GI side effects, but unfortunately the most commonly reported side effects are nausea, vomiting, and constipation. This serotonin 3 antagonism is also thought to have cognitive enhancing properties, but this needs to be further studied. Vortioxetine is also involved in CYP450 interactions, and
In summary, our goal of treatment in depression is to really induce remission and prevent relapse. The antidepressants are equally efficacious but differ in their side effect profile, and there may be one agent that happens to work best for one patient, and sometimes it requires trying multiple agents before finding that correct drug for that patient. SSRIs, SNRIs, bupropion, and mirtazapine are considered first line due to having less adverse effects in drug-drug interactions than things like the monoamine oxidase inhibitors and the tricyclic antidepressants. It is important to monitor for suicidal ideation in all patients, but especially our pediatric and young adolescent patient populations. It's also important to remind patients that adverse effects occur immediately, while resolution of symptoms can take anywhere from 2 to 4 to maybe even 6 or 8 weeks. Thank you for your time.